All right, everyone, welcome back to another episode of ICU. Today I have Dr. Sonia Bahlani with me, and I'm really excited to chat with you, Sonia, about the topic of pelvic pain and maybe how you are treating interstitial cystitis, painful bladder syndrome, and other bladder conditions in your practice. So, welcome to the show.
Thank you so much for having me. I love talking about this stuff and this is going to be fun.
Yeah. Would you mind taking a second to just introduce yourself to the audience? Who are you? Where are you? All the things.
Yeah. So my name is Dr. Sonia Bahlani. I'm a New York City-based pelvic and sexual health specialist. I trained actually at Cornell here in the city, and then I went ahead and did training in urology with, I think, Rob Moldwin, who you've had on your podcast before. And then I stayed on in academics as his partner for almost 7 years until I went off on my own because I think treating this stuff is so important and just requires a lot of time. And often in academic settings, you don't get that time. So I love what I'm able to do with this now.
Yeah, that's amazing. What really brought you to, the women's health, pelvic health world specifically?
So when I was training, there was this doctor at Cornell. His name is Dr. Ledger, and he really pioneered the field of vulvodynia, which often we have like other specialists in now. But as I was training with him, I would see that so many women suffered from urological symptoms as well. So they'd say, I'm having all this vaginal pain, but I also have a lot of frequency, a lot of urgency, a lot of pain when my bladder fills. And so then they were being tossed around to urologists, back to the gynecologist, to the urologist, and they were so frustrated not having their needs met. And so when I was training, Dara, who's another resident, was working with Rob, and she said, "I think you should meet him." And I did, and then he literally on the spot was like, "Be my fellow. You're so interested in this stuff," and that's how it happened.
Yeah, I love that. That's awesome. And Dr. Moldwin is a really cool guy and really knows his stuff. So that's awesome that you were able to train with him. So I'd love to dive into the topic of pelvic pain more because it's a topic we've touched on this podcast before. We're like 80 some episodes in, and I feel like we haven't done an episode specifically on pelvic pain yet. So would you be able to take us through, like, what does the term pelvic pain mean?
Yeah. So the true definition of pelvic pain is pain under the umbilicus, so like under the belly button, towards the pelvis that can go all the way around the back that exists for over 3 months. Okay. It's a very generalized, non-specific definition. And it's partly what makes treating pelvic pain syndrome so elusive. Because what are you treating? Where is that pain coming from? And I know you talk about this a lot in your work, and I talk about it a lot in my work. It's essentially figuring out what the true root causes are. Okay. And I will be very honest, in terms of treating pelvic pain, there is more often than not more than one true root cause. So most people don't just present with endometriosis, or don't just present with IC, or don't just present with vulvodynia. There's often a combination of sorts, and we have to understand what's happening and peeling that onion to really treat someone so they can get true relief.
Okay, got it. In terms of specific symptoms that people are coming to you for that fall into that pelvic pain definition, like, what are you typically seeing?
So there can be a whole amalgamation of symptoms. So some of them can be urological, meaning people can present with things like urinary urgency, frequency, pain with bladder filling, pain with urination. They can be GI in nature, so pain with defecating, pain after defecating, pain with sitting for long periods of time. They can be reproductive in nature, so pain with intercourse, both with initial or deep, pain after intercourse, or an uptick in urological symptoms, so frequency and urgency after intercourse. So there can be a whole host of symptoms, which is why I think people are often misled, because they're often told, oh, it's just IBS. Oh, you have OAB. Oh, you have endometriosis, without getting a true diagnosis, because all we're doing is treating that patient as a fragmented portion. We're only saying, let's just treat this, instead of looking at the whole body and saying, wait, perhaps the urgency and frequency is a compensatory response from the pelvic floor. And while it sounds like IC, wait a minute, it might not be IC, it might be pelvic floor and something else.
Right. Yeah, it's definitely complex, and I'd love to hear more about your approach. If somebody's coming into your office with some of these symptoms, like how are you like leading that appointment?
Okay, so number one, I love this question because it's exactly why it's exactly why I started my own clinical practice and left academics. I love academics. No one goes into academics thinking they're going to leave it, right? But let's be quite frank. Our medical system is a tad broken, and we're often, as clinicians, asked to see patients in a matter of 15 to 20 minutes. Callie, you can't diagnose pelvic pain syndromes, whatever you're treating, in 15 to 20 minutes. You're going to miss something. So my appointments in my office really range from like 60 to 90 minutes for a new patient exam, because we're going through a thorough history. I review all prior imaging, even though that's often normal, all prior lab results, because, we can talk about low count bacteria, IC, interstitial cystitis, and then we're sitting down and we're talking through every single symptom. When it started, did you notice any other triggers with that? How, and as you know, pelvic pain syndromes, they go like this. They fluctuate. They go up, they go down. So people do better, then they do worse. And you really need to get into the nitty gritty of that. Genetic issues, like did mom ever have these symptoms? Did dad ever have these symptoms? Because understanding that genetic component is really important, because we know that someone with, for example, with IC is 70% more likely to have a first degree relative with IC. So like we have to understand the genetic and environmental components that can be playing a role in someone's symptoms. And then we do an exam, and the exam is really like threefold. So we do, like, I take a look at the vaginal area under colposcopy, like under a microscope. Okay. And believe it or not, I see women and men. So people don't realize that, but I do, because a lot of men suffer from pelvic pain syndromes and they know where they can go. And then we do an exam of the bladder and pelvic floor, a Q-tip test. And then we sit down and we talk, but I'm not like catheterizing every person that walks in the office. I'm not doing a cystoscopy for every person that walks into the office, because it's unnecessary, and that's not really what you need to be diagnosing and treating people properly.
Right. Are you seeing any trends among your patients, like a lot of bladder pain or a lot of like, I don't know, symptoms that get worse at certain times of the menstrual cycle, like anything like that?
Mm-hmm. Yeah, definitely. I mean, so even with IC, I think that's like one thing, at least, and I know like you might have talked to other people about this, but I feel strongly about it, where like, have you ever heard of like when someone comes in and they're like, oh, but my symptoms get so much worse right before my period, or
Mm-hmm.
right before ovulation? And they're often told by other providers, oh, if it's right before your period, then it's endo, because that's your period and there's that. But when in fact it could be IC, and that's very notorious for interstitial cystitis, because you get an uptick in symptoms before your period due to those increase in inflammatory cytokines that are occurring, yes, secondary to hormones, but it's more of an inflammatory reaction that's triggering it rather than a hormonal one.
Right. I'm curious, like, what do you do for those patients?
There's so much to do. I mean, number one, one really basic thing that you can do is a mast cell stabilizer, like an anti-inflammatory prior to their period, to see if that downregulates the inflammation, to see if that gives them the relief. That's somewhat diagnostic and therapeutic. The only problem with that is that medications often take a little while to start working. So you might not see that boom effect that you're getting like almost immediately. Do you know what I mean?
Yeah.
I really reserve bladder installations for like down the line. Do you know what I mean? Like if someone's
Yes.
having a flare and unable to break it and it's consistent, and we really believe that we need to like kind of retexture the bladder lining, then that's when I'll offer installations. But it's definitely not my first line, simply because catheterizations in and of themselves can be irritating to patients with IC, especially when most patients with IC have concomitant pelvic floor dysfunction. Do you know what I mean? And
Oh,
so
yeah.
times treating the pelvic floor and doing stuff like pelvic floor PT, Valium suppositories, even if needed, Botox to the pelvic floor can oftentimes help to settle interstitial cystitis like symptoms because of that correlation there.
Hmm. Yeah, and that is kind of what Dr. Moldman said was his approach to the cystoscopy process when he does one is because I was asking him, like, there's a lot of people in the IC community that are terrified to get a cystoscopy done. And, like you said, pelvic floor dysfunction is usually present. So what he said is he recommends doing pelvic floor PT even before that cystoscopy just to like calm everything down. So it kind of sounds like you're taking a similar approach, but with the installations.
Yeah, I mean, with installations or a cystoscopy, like the way that I think about IC, so like, like kind of how it goes through my head and why I do it this way is like, what is interstitial cystitis? It's when there's chronic inflammation that can lead to a degradation in the gag layer of the bladder, right? Or the glycosaminoglycan layer. So essentially, there's holes in that gag layer, similar to like if you're outside in the rain wearing a rain jacket with holes in it. You're going to feel the rain a lot more, right? If you have IC and if you have holes within that gag layer of the bladder, you're going to feel everything more, which is why stuff like diet is so important, like, and not like across the board, right? But understanding actual triggers is very important for patients. But what does that do over time? It increases a neuropathic uptick to the bladder, right? So you feel everything. You're centrally sensitized. Your nervous system, your barometer has shifted, right? So now a simple citrusy food or like a simple sitting for a longer period of time or sex can trigger this whole flare to occur. Whereas like if your barometer started from here, you might have a smaller uptick. So the way that I think of pelvic floor physical therapy and just like pelvic floor in general is like if we can down regulate the pelvic floor, we can at least peel the onion on that one aspect that could be adding fuel to the fire. And for a lot of patients, that fuel to the fire is the crux of the fire. Do you know what I mean?
Mm-hmm. Yep. No, I love that approach. And I wish my doctors way back when I was doing all my stuff took that approach as well. Because it was like, okay, we're diagnosing you. Let's get in and do the hydrodistension. Let's do the installations. And I was like, holy crap, like all of this hurts really bad. My anxiety is through the roof. I'm terrified of all of this. And of course, nothing ever helped me. Like,
No.
no wonder.
And that's such a good point. Like I love that you're being so honest and actually didn't know that. So thank you for sharing that. But the whole concept of hydrodistension now, even, and people ask me this all the time. So I feel like I need to speak to it because they're like, oh, so like I had a hydrodistension and I got better for like 2 weeks and then I got worse and then I got much worse. And the whole concept of a hydrodistension is to overstretch the bladder to cause a neuropraxia, to downregulate the nerves going to the bladder. But what's the problem, Callie? Nerves can regrow. So when you stretch the bladder and you downregulate the nerves, that's a short period of time. Guess what happens after that? All the nerves start firing even more frequently and in fact at a higher level. So hydrodistension is not even considered standard of care anymore. It's not something that should not be your first line. It shouldn't even be your third line, to be quite frank. So it's so interesting to me how the world of IC changes, like so quickly. And that's why I also find sometimes like well-meaning doctors, if you're not staying up to date and current on the IC literature, you're doing stuff from like the dark ages. You know what I mean? And like that can potentially make people worse.
Totally. There's still doctors that are doing like the potassium sensitivity test.
Well, that boggles my mind. And there's still doctors who are doing hydrodistension. I mean, like,
Uh-huh.
or dilatations. I mean, it's like, it's,
I see it in support groups all the time. People are like, my doctor wants to do the hydrodistension. Should I do it? Should I not do it? And I'm like, I it made me worse. Kind of like you were saying, I went into it with just bladder pain. I had no frequency or urgency. I came out of it with incredible frequency and urgency. Like, and my bladder pain didn't change.
Yep. Yeah. And it's also similar to medications like amitriptyline, nortriptyline. These are medications that are used to be standard for IC. And the problem with them is that number one, they don't often work. And number two, when you start patients on them, they get things like weight gain, constipation. If you have a patient with IC and pelvic floor and you give them amitriptyline and they become constipated, you're going to worsen them. You know what I mean? And so I think that's part of the problem too, is like when you don't know what you're treating, you're simply looking to mask symptoms, and then people are getting worse, and then they're more confused. They're like, so does that mean I don't have IC? Does that mean that we're missing something more glaring? And that's another problem I see a lot of people run into.
Yeah. I was going to ask you, are you prescribing a lot of medications or do you kind of wait for that stuff?
I do prescribe medications, but not as first line, to be quite frank. Number one, I'm so careful when I'm giving the diagnosis of IC. Like, it's not a label I will put on someone without really fully, like, 95% thinking that they have it. Okay. And partly because, kind of like you're describing, IC and OAB, they're in this spectrum, right? They're in this spectrum of urological symptoms. And I'm not saying that I think people have OAB. I think that that's ridiculous too, when people are diagnosed with OAB for like, and they have IC. But my point is that I think there's first line many other things we can do, whether that's even understanding true dietary triggers, which is like why I would send them to someone like you. I'm not a nutritionist at all, and I fully admit that. But you know what my pet peeve is? When people give patients the IC list, and they're like, here, I mean, blueberries are, you know what I
You're
mean? I'm like,
preaching to the choir right now. Like, this is I could talk about this forever, but I cannot stand hearing when doctors like giving the pamphlet, not explaining how to do it, how long to do it. People are thinking they have to follow this diet forever, and then they come to me and I see nutrient deficiencies, I see weight loss, and I see food fear. And it's so much worse. Like, their symptoms are so much worse because of the lack of education.
absolutely. And I mean, and like you said, nutrient deficiencies, if I say that, you follow that list to a T without someone explaining it to you, I mean, you're going to be depleted. Like, there's
Yep.
just no way. And people not even like clearly explaining triggers, like, being like, oh, I'm not saying that, like, being like caffeine's a bladder irritant. We know that, right? But caffeine's going to make everybody pee more frequently. It stimulates AD. That's how it works. Do you understand what I'm saying? But when you don't explain an actual trigger to someone, they don't know what they're looking for. They know they're in pain, and now they're told that they have to like be fearful of every food under the sun. While I think diet is really, really important, I really like I like to work with like nutritionists like you, because I'm not the expert there. Nor, to be quite frank, do I have the ability to sit down for a few hours and go through every food. But what I can offer is things like, okay, so then I do the pelvic floor exam. If the pelvic floor is spasming and flaring, then yeah, they're going to start PT immediately, because that's an easy kind of peeling of the onion there. If we need to, I will often start things like Valium suppositories and stuff like that, just to get the pelvic floor, because muscles have muscle memory, especially if they had symptoms for a long period of time. PT alone, often you need a little something more than that. And then, there's so many things that we can do for the bladder in and of itself, whether it's anti-inflammatories, whether it's beta-3 agonists. And while all this stuff has a small amount of data to it, every small win gets someone in the right direction. And then, like I say in my practice, medications are rafts. They're tools we use to get you to the next spot. It does not mean that you need to be on a medication for the rest of your life. It means that it helps us understand what your true root causes are. It helps us kind of peel the onion so we understand how much of it is coming from here and there. And then ultimately we take you off of it. And that's the goal.
Right. Exactly. Yeah, I've had a lot of clients coming to me on so many different medications, and I'm like, this just feels like a lot. It feels like some doctors are just throwing as much as they can at people, and it's like, okay, is this actually getting to the root of the problem, or is this just like masking things?
And on the converse to that, I also see a lot of doctors, like how we had talked about OEB and IC, who are like, oh, maybe they have IC like symptoms, like they have pain with bladder filling and they have frequency and urgency. They ignore the pain with bladder filling and they put patients on anticholinergics, and they also have pelvic floor, and that can put someone with IC into full-blown retention. So now they feel like they have to pee, but they can't even get it out, and so they don't even get that minute relief that they normally get from voiding. Do you know what I mean?
Hmm.
And something that I see a lot of too, and it's because it's like two spectrums. It's like the amitriptyline, nortriptyline, gray lease, all these meds, and then it's like the OAB meds. You can't just, they're both going to cause issues if you're not treating properly.
Right. Yeah. And in terms of, I know we wanted to talk a little bit about supplements. Like, I'm seeing a lot of people coming to me on like literally 5 to 10 different supplements, and they're like, I don't even know if any of this is helping me. Like, what is your stance on supplements?
I think that for there are data driven supplements, at least that I think in my field, and I'm sure you can add to this. Okay, so here's the ones that I think of, and then I kind of do want to hear like your take, if we can go back and forth.
Yeah.
We can go from there. Quercetin. Okay, quercetin is a data-driven supplement. Is a great bioflavonoid, decreases inflammation. Initially studied by the Cleveland Clinic for chronic prostatitis, but isn't everything studied for that? So who cares? But I think that that's a pretty helpful supplement, and I think it's a good one. Vitamin D supplementation. I mean, this was something that was looked at now for years, and it's helpful for the binding of different types of bacteria to the bladder wall. And I think that that's one that can truly be at least 2,000 units. You don't need super high doses of vitamin D. Do you know what I mean? Just a good amount. And the third supplement I really like, and these are for my pelvic floor people, different types of magnesium, depending on what we're treating. You know what I mean? Like mag citrate for constipation. We're looking at malate for anxiety and stuff like that. But like, I think that magnesium supplementation, we don't extract magnesium from foods like we used to. And I think that that's one that I take myself like daily. And I found it to really help, especially with me, like being in a certain position all day, like that neuromuscular tension is super helpful for that. Now you
Hmm.
tell me. Curious.
No, no, no. I love all of those recommendations. I think that's great. I see a lot of people on Desert Harvest aloe vera, which I support. I think if you're going to do aloe, that's the best brand to go with. Super reputable. They've done their own research, which is good. Trying to think what else I see a lot of. I mean, yeah, you kind of hit the main ones.
And then the other one I always get asked about is D-mannose. I'm sure you get asked
Mm,
about that all the
yeah,
time.
yeah, we get that one a lot.
Well, I like it. I mean, I think for the data for recurrent UTIs, at least for catheterized patients, is there. Okay, is the data necessarily there for IC yet? No, but it's definitely a supplement that in general can be helpful for low count bacteria if someone's really harboring a low amount of bacteria and that's triggering their flares.
Hmm. Yeah, no, I have no problem with D-mannose, especially if there is like a history of UTIs. I mean, I don't know about you. Do you ever see patients coming to you after seeing like a functional medicine or naturopath that are on like a dozen supplements?
Oh
Does
my
it drive
god.
you as crazy as it drives me?
Yeah, because supplements are not even like, and I know you know this, but like they're not even like regulated by the FDA, right? So when you're on like 12 to 15 supplements and we have no clue where you're sourcing it from, and then you're like, oh, this is flaring, like you don't know what variable you're dealing with at that point. You know what I mean? And yeah, I see that a lot, and it's very frustrating. And if anything, sometimes I think it makes people a little sicker.
Yeah, and not to mention they're not cheap. Like
Oh my god.
it's crazy how much these supplements can cost.
They're not cheap at all, and often they're taking, like, it's kind of like the Elmeron theory. They're taking 6 months to start working, and so then you don't really know whether it's the medication that's working versus like the natural course of IC or a different pelvic pain syndromes kind of running their course. And
Yeah.
so it throws in that huge variable. And I agree. I mean, it's definitely I love that you're saying that, because I feel like a lot of people don't say that. I feel like, and it's the problem because, people who are suffering, they have unmet needs. And so they're going to a functional medicine doctor because maybe their urologist or their gynecologist is not meeting their needs, and that's the saddest part.
Yeah. And I mean, I was once in pain and desperate for any type of solution. I would have given you my dominant arm if it meant getting relief. And I tried literally everything. I did not go to a functional medicine doctor just because at that point, like, I didn't really believe in that stuff. I was in college and everything, but um, I understand people wanting to go down every avenue possible. It's just hard for me to watch somebody go down the functional medicine route and then be diagnosed with things that are kind of iffy, like leaky gut and um, like parasites, all of those kind of, not
Yeah.
really,
Yeah.
yeah, you know what I'm
Yeah.
saying, and be sold these supplements that, really aren't super evidence-based, and then like people are out thousands of dollars, and it's like, okay, you're I mean, a lot of people I'm noticing aren't addressing like their chronic stress and the nervous system, and they tried pelvic floor PT once, but it didn't really help, and it's like, okay, maybe we should try somebody else. Like, there's certain things that you kind of skip over, and I'm so guilty of that. I skipped over all of that stuff when I was going through it. So I can't blame anybody for doing this, and I don't want it to come off that way of like I'm being judgy or anything. It's just hard to watch somebody spend that time, spend that money, and then end up potentially at the same spot or worse off down the line.
Yeah. I mean, it is so hard. And I think that's the hardest part, is the unmet need. So you're willing to do whatever it takes. It's a vulnerable population. And you and I both know that, having suffered even yourself. Um, and I find that that's the hardest part for my patients too, because they often don't trust doctors, right? Because they've been to so many people. And so by the time they get to me, even though I want to be their last resort, like their last stop, um, they're scared, and the nervous system stuff is stuff that I think, should be shouted from the roof, because what are you gonna do when you're in pain? You're going to clench, you're going to contract, your nervous system's going to be upticked, and we're not at all, even as clinicians, talking about the fight or flight or living in constant fight or flight. We're not talking about parasympathetic or vagal activation. And how can you do that when you have 20 minutes with a patient? Do you know what I mean? And it's
Mm.
why programs like yours are so important. It's why appointments like mine are so important, because you got to put all the pieces together, and that's a lot of work. It's a lot of work to put all the pieces together and try to really get, that level of what I call remission.
Mm-hmm. Exactly. Yep. Fully agree with you on that. You mentioned earlier, you really try to get to the root cause in your practice of these symptoms. And I have my thoughts on the root causes that I see most frequently with my clients, but I want to hear like from you, what are you seeing? Like, are you seeing a lot of people being misdiagnosed with IC and it's really endo? Are you seeing like some pudendal neuralgia? Like, what are you seeing?
I am seeing, yes, wow. I would say I'm seeing so much misdiagnosis, okay? And in many ways. So number one, I'm seeing a large proportion of patients being given a diagnosis of endometriosis without a full evaluation. And once they're given the diagnosis of endo, at least, and I don't know if this is also a little bit of being in New York City, and so you have a lot of endo specialists in one place. Do you know what I mean? And I'm seeing a lot of people undergo surgery for endometriosis, but then still coming into my office with continued pain. And that's why my philosophy, I stand so strongly on my philosophy, is like using medications diagnostically and therapeutically to understand the percentage of what different generators we have going on, so that someone's not having a procedure and not getting the benefit they want from that procedure, increasing scar tissue formation, that kind of stuff. I see a lot of misdiagnosis, believe it or not, of IC. I see that a lot of patients with pelvic floor are given a diagnosis of IC without even having a pelvic floor evaluated. I would say 80% of patients who walk into my office with the diagnosis of IC have never been evaluated properly for pelvic floor dysfunction.
That it blows my mind, but I'm also not surprised by it. Like, why is this happening?
I think that, and people, like at least clinicians and doctors, are not taught how to properly examine the pelvic floor. I think they're often also, if we're really going to be honest, Callie, part of this is insurance-based issues like interstitial cystitis, pelvic pain syndromes. They're not well reimbursed to physicians. So oftentimes you are getting someone who's just trying to get you in and out to see X amount of patients a day. Do you see what I'm saying? And so there these big glaring things that should be properly evaluated are not being properly evaluated, either due to lack of education or lack of time.
Super sad and disappointing, but it is the reality. But I completely agree with you. I get a lot of clients that work with me who they either haven't been evaluated for PT, maybe, or pelvic floor dysfunction. Maybe their doctor doesn't value going to pelvic floor PT and being evaluated by a pelvic floor physical therapist. And that's shocking, but I mean, again, it's a reality. There's doctors who are diagnosing without even doing like a pelvic exam. They're not even touching the patient.
I mean, and then you're also seeing the advent, and I don't want to talk about this like negatively, but I'm just saying you're also seeing the advent of people who are noticing more people being diagnosed with pelvic pain syndromes and then coming out as these specialists, but not having the training or not even looking at the training for this. So then patients are being misdiagnosed. Do you see what I'm saying? And they're undergoing things like a cystoscopy or like different procedures that ultimately are not giving them any answers. It's really actually problematic. And I hear you loud and clear. And so, I mean, like, number one, everyone needs to be educated on how to evaluate a pelvic floor. You should be evaluating the pelvic floor before you do a cystoscopy 100% of the time. Like, there's never a situation in which someone should walk into your office and immediately get catheterized or immediately get a cystoscopy. You know what I mean?
Yep, totally agree. I know you have to run to the OR soon, but I wanted to give you a chance. Like, is there anything else you feel is necessary to discuss with my audience before we wrap this up?
One interesting thing that I think, which will be a whole topic, I'm sure, on your podcast one day further, is this whole concept of the vaginal and bladder microbiome and how it relates to things like interstitial cystitis or all kinds of pelvic pain syndromes. And, there are not great answers yet, but there's definitely strides. And I think that understanding why someone who's on birth control for over 5 years has an altered vaginal microbiome and then develops either recurrent low count bacteria, UTI, or bladder based symptoms is not in the minority anymore. Do you know what I mean? And so I think that's definitely a topic that I find a lot of patients are coming to me more for now, that they're having a lot of trouble understanding because no one's really talking about it. But it needs to be talked about because there is a relationship there. And if we don't understand the relationship and if we don't treat properly, then that's another issue that's kind of playing a role in our careers. We're seeing it a lot.
Okay. Yeah, I feel like that would have to be a whole other episode. I did have someone from the company EVVY. They're like a vaginal testing company on the podcast last season, and we talked about it. But that's a topic for me that I'm going to need to hear like 1,000 times in order to feel at least a little educated on it.
Well, and you're right, but it's not even like you need to hear it 1,000 times. There's also 10 different perspectives on it. Do you know what I mean? I mean, like, you have Microgen, you have Evie, and even then, you have doctors and I know there's many of us who are like, but what does that mean? Do you know what I mean? But what are we looking for there? And why? Because you run the risk of over-treating a patient with antibiotics. You know what I mean? And so, and especially with someone with with, vaginal or bladder symptoms, that can be cause a whole host of issues. So it's definitely something where like we could hear it 100 times, and I bet you every time we hear it, it's going to change, because that's the nature of where we're at with that stuff.
Yeah, totally. And you're always welcome to come back on and we can talk about that more.
Amazing.
Cool. So you're currently practicing in New York City. Are you accepting new clients or patients?
We are, yes. We do have a bit of a wait list currently, but we are accepting new patients, and I do my best to try to get everyone in as much as early as I can.
Yeah. Do you have people coming to see you from out of state?
Yes, I would say out of state and out of country for sure.
That's awesome. Good for you. You obviously are running a pretty good operation over there and helping a lot of people. So, yeah, we'll link all of your information in the show notes. And yeah, I just want to say thank you so much for coming on and giving us your time and your expertise.
Thank you for having me. This was great, and I appreciate all you do as well. So I'm glad that we finally got to connect.
Me too.